Good morning or good afternoon, depending on where you are in the country, and welcome to the AGA Institute webinar on what to do with our ASCs. I'm Dr. Larry Kaczynski. I'm the chair of the Practice Management and Economics Committee, and I am going to host this session today along with two of my colleagues who you will meet in a minute. The situation today in ASCs is just this. If you could turn the clock back to 2007, a long time before the real estate bubble burst and the stock market crashed, most of us would take that opportunity to move our valuable, vulnerable assets to safer harbors. Just think of how much you could buy today with that money if you only had it. Well, healthcare is sitting just like real estate was in 2007 today. There is a storm coming which is going to leave us changed forever. We may never see reimbursements in the future like we are seeing today. Those of us who are sitting on large healthcare assets should be asking ourselves if it isn't a good time to cash some of our risk in at this time. For this reason, we thought it would be appropriate to discuss what to do with our ASCs. Many of us have large investments in these ASCs. It's time to assess the risk on these assets. As I said, I'm Dr. Larry Kaczynski. I'm going to give one view, one version of what to do. I'm joined today by Dr. Fred Rosenberg, a partner of mine in the Illinois Gastroenterology Group and one of its other managing partners. He sold his ASC in the past to a management company, and we'll discuss how this has affected him. Also joining us today is Ken Stropel, President and CEO of Downey Regional Medical Center in California. He will educate us on why it is better to partner with your hospital. Next slide. What are our goals today? Well, we're going to try to define the current state of endoscopic ambulatory surgery centers, investigate some strategic options, delineate options that affect physicians at different points in their careers, and finally, assist our membership in deciding what the future should be for our endoscopic ASCs. Next slide. The agenda. We're going to first present the case for selling to a management company, and Dr. Rosenberg will assist us with this. Then we will be moved to the case for selling or partnering with your hospital, and Mr. Stropel will handle this. And then finally, I will come back and present the case for maintaining your own control. Next slide. What is the current state of our ASCs? Well, I think we'd all agree that we're seeing declining reimbursement, increasing costs, which is resulting in compression of our margins. There are growing, increasing quality measures and requirements that we need to maintain, and we see the vulnerability of our current services as changes occur around us. There are accountable care organizations arising, bundled payments, episodes of care, an uncertain future surrounds us. Next slide. So let's talk to someone who's already made a decision in this regard, and I'm going to turn over the webinar at this point to my partner and friend, Dr. Fred Rosenberg, who's going to advise you to sell your ASC. Good morning, Fred.
Good morning. Thank you, Larry. Good morning, everyone from Chicago. Thank you for attending this webinar. I have been an owner and partner in the North Shore Endoscopy Center since 1996. I'd like to share with you the story of our facility and the reasons that led us to partner with a management company about 6 years ago. I put up this slide for several reasons. First, March is colon cancer screening month, and colon cancer screening is increasingly recognized by the public and the payers as a very cost-effective means of decreasing deaths from colon cancer. This is a mission in which gastroenterologists and outpatient endoscopy centers must be in the forefront. The direction of the practice of gastroenterology has shifted substantially in the past 30 years. When I began my practice in 1978, endoscopic procedures made up less than 25% of professional practice revenues. Last year, those endoscopic procedures accounted for more than 60% of the work we did. It's likely that this trend will continue. And finally, this graphic is from our endoscopy center website. The Internet is becoming an increasingly important tool for communication with our patients and our potential patients. Like many of you, I'm sure, we no longer spend any dollars on Yellow Pages advertising. and we will become increasingly reliant to new technologies to interact with our existing patients and to attract new patients. Next slide, please. To understand why we came to the decision to partner with a management company, I'd like to tell you the history of our facility. In the early 1990s, we recognized an opportunity to capture revenues associated with the procedures we do. Outpatient endoscopy was just beginning around the country. At that time, professional reimbursement for a colonoscopy was about $600, and the hospital charge was about $700. After nearly 3 years of planning and working for approval from the Illinois State Facilities Health Planning Board, and then finally construction, our facility opened in 1996 with 2 rooms and 4 physicians. By that time, hospital facility charges for endoscopy had risen to over $1,000. And while it was relatively easy to gain insurance contracts, 15 years ago, the concept of having procedures done outside of a hospital was still quite a novel idea, and for some patients, a location for health care they were not ready to consider. It took nearly 3 years for the facility to become debt-free and generate income for the partners. Next slide, please. Even with the early challenges and financial struggles, we always felt good about our facility and what we were accomplishing. We were able to create a facility that, from our point of view, put patient safety, comfort, and convenience first. We designed a workflow that was mindful of physician needs. Because the staff with whom we worked on a daily basis were now also our employees, the work environment was totally different from what we experienced at the hospital outpatient departments. When issues or problems arose, we were the decision makers and not reliant on the whims of administrators who answered to others and considered the issues related to GI in the context of the much larger hospital environment. In the mid-2000s, our center was busy, our patients were happy, our staff was happy, and we were happy. So why change? Next slide, please. One of my favorite quotations comes from an Italian author, Giuseppe de Lampedusa. If we want things to stay the same, things will have to change. 15 years ago, the obstacles to the successful development and operation of an endoscopy center were modest and limited. Physicians with a bit of entrepreneurism, some hard work, and the assistance of capable staff, advisors, and consultants could provide a facility superior to a hospital setting at lower cost to patients and insurance companies and still generate a profit. Today, there are constantly changing new rules and regulations, as well as agency oversight in areas such as infection control, patient life safety, human resources, which typically require significant documentation of compliance. This has added a level of complexity which often puts the operational management beyond the capability of a physician who must devote time and resources to the increasingly complex demands of his professional practice. Partnering with a healthcare organization can be one means of shifting some of the operational duties to full-time professionals. While local hospital systems would seem to have an advantage in understanding the local market, their interests are not focused solely on the provision of outpatient services. Even more importantly, their market vision is not typically aligned with the interests of private practice gastroenterologists. National ASC organizations bring great expertise in the management of private practice outpatient facilities. This is their only focus. Their success is dependent on their performance in the management of the facility. In that respect, their interests are perfectly matched with those of their physician partners. A national ASC organization has the legal and nursing support staff dedicated to keep up to date with the changing regulations, policies, and requirements. Being part of a national group of endoscopy facilities makes possible the sharing of the best clinical practices and procedures. National organizations often have leverages in buying and purchasing contracts, as well as increased clout with insurance companies. Being part of a national group gives a louder voice with respect to GI advocacy issues. In these uncertain times for healthcare, monetizing part of the facility investment by partnering with a national ASC company can allow physicians to protect the investment that they have developed and give it the best chance to continue to thrive in the future. Thank you.
Audio. Mr. Stroppel, are you on?
Yes, I am.
If you can begin.
Sure. Let's see. I guess we're going to need the next slide. Hi, everybody. Maybe a little background on my facility will kind of put a lot of this in perspective as we talk about, why I think it's the best idea for a gastroenterologist owning an ASC to partner with his local hospital. Have a 199-bed Vanilla Community Hospital in southern LA County, city of Downey. There's a freestanding ASC in the community that's multi-specialty. Obviously, they do a lot of gastroenterology there. But I'm looking at this whole concept from the perspective of what does the future of medicine have to hold? How does it affect the local physician, whether they be primary care or specialist? But at the end of the day, how do we all succeed and develop the options necessary to, I'm going to say, flourish in a future that really hasn't been well defined till now? So if I could have the next slide, please. As a preface, additionally, for those of you that aren't from California, Los Angeles County is probably the most highly managed care location in the country. And so we're out there learning how to do things. We've been doing a lot of managed care for a long time, but the health plans have now gotten into the act, buying up medical groups, be they large or small, and so it's becoming a very interesting environment. From my perspective, healthcare reform is here to stay. Whether we like it or not, healthcare reform in some form or another will be here. Whether we could talk about ACOs and whether or not the shared risk ACOs or the pioneer ACOs being promulgated by the federal government are really going to turn out to be realistic. It really doesn't matter. The terrain, the reimbursement mechanisms, they're all changing. The risk is going to be pushed upon, obviously health plans, but hospitals, physicians, risk is going to be the issue that we all have to deal with. How do we take care of the patient and at the same time survive financially? What I'm seeing in my community is providers consolidating at all levels. As I mentioned previously, we've got medical groups buying medical groups. We've got 1206L foundations, which in California we cannot own, hospitals cannot own medical groups or employ physicians. So you have interesting legal things that you can do to amalgamate physicians and physician groups, but they are consolidating. Health plans are buying medical groups, which creates a very interesting set of circumstances. But all in all, the integration is well underway in our healthcare environment here. The real question for me in owning an ASC or wishing to dispose of an ASC, if you will, can you accept financial risk in the future, or are you going to become a commodity? And when I say become a commodity, I really think that what's happening is the health plans are ultimately going to buy health care based on quality and cost, which really commoditizes much of what's out there from a service point of view, including hospitals. And then the other question that I've got is, are freestanding or management company-owned ASCs positioned for the uncertain future? What kind of options do they have before them? We don't know what the future is going to be. But all I can tell you is it's going to be much different than what it is today. Can we have the next slide, please? Obviously, I'm not a physician, but if I was a physician considering the selling of my ASC, or at least selling part of it, I would look at it in many of the same ways that Dr. Kaczynski is looking at it. First, you got changes in regulations out there daily that will affect the practice of medicine. And the one that I find problematic in the future for physicians, whether or not this actually comes to fruition, but there's a distinct possibility Stark will be tightened to eliminate ASC ownership by physicians. And if that happens, obviously the value of a ASC becomes less and less. But then the real question is, given the uncertainty of the future and the reimbursement mechanism changes that are going to occur, will that really matter? Just a rhetorical question. Integrated delivery systems will make delivery decisions based on cost and quality. It's really going to be a make or buy decisions. And let's say for a second that we have ACOs in place, some type of global reimbursement. Let's say there's a medical group and a hospital involved, or even a health plan. It's really going to come down to where can they get the service at the lowest cost and get the best quality. And that's just going to be a make or buy decision. And I find it hard to believe that at the end of the day, given the fact that hospitals, for instance, with respect to an outpatient procedure, the fixed overhead's already covered, and the outpatient procedure really is going to be able to be priced on the margin. So the ability or the need or the choice to send that patient to an ASC owned by a specialist probably is going to be limited, because if we can do it at a lesser cost in a different location, we will do that. In my environment, hospitals are already, including me, decreasing prices to our marginal cost or to close to that in order to get back, or in order to allow the health plans and the medical groups who are heavily driven by cost to put that patient back in the hospital on the outpatient side, thereby forcing the gastroenterologist to do the procedures in the hospital. Many hospitals are capable of doing this. You just have to know what your costs are so that you can make sure, obviously, that you're not going to lose money on the volume. This is kind of a repeat, but service locations will be made by the payer instead of the surgeon and the proceduralist. Price and quality are going to be the determining factors. And as most of us have already read over the past month, there's a lawsuit out there driven by Aetna about out-of-network billing. That's the outcome of that's going to be very interesting and will most definitely affect reimbursement for ASCs for all of this out-of-network billing that's going on, including in my local community. And not being an ASC owner, I don't get into the financials of the local surgery centers, but I know this one that I work with, and I have to presume it's the same throughout the nation. Out-of-network billing is a significant revenue source. Can I have the next slide, please? I tried to look at the benefits of a local hospital partnership from the perspective of the physician. Simply put, the hospital will benefit, obviously, just due to the volume and not having to split patient loads. The politics change when physicians have their own center, practicing doing part of their practice in the hospital, part of their practice in their own center. That goes away from the hospital's point of view. But from the physician's point of view, the potential hospital competition is obviated. And from a hospital's perspective, I don't really want to compete with my medical staff, and it doesn't do anybody a lot of good. I think we're better off doing things together as opposed to individually, but by the same token, obviously, physician incomes have dropped, and they're looking for other sources of income. An ASC is such, or at least was such. But the hospital competition is a big issue for me politically. Let's pick on gastroenterologists. As a gastroenterologist, you need a hospital. And as a member of the medical staff, as a hospital partner, you do have input and influence on the hospital activities, whether it be purchase of equipment, supplies, operational activities. From a hospital management point of view, I need the physician's input because they're taking care of the patients. I see that as a benefit for the physicians. And as the regulatory climate changes, an ASC partner, hospital as an ASC partner, will become the immediate purchaser of any remaining interests owned by the physicians. And I really do see the regulatory climate changing in the future. And at the end of the day, hospital availability It's immediate, and you're already a member of the medical staff, so when you have a problem with a patient, there really isn't a big debate about where that patient's going to go and who's going to care for it. You'd still take care of the patient while they're in the hospital. Some more benefits that I see. Being part of something integrated and larger provides options for an uncertain future. This is really translated from my view of a hospital itself. I'm a freestanding hospital in a community that probably serves, I don't know, at the end of the day, a patient population that exceeds 1 million patients. There are other competitive hospitals in my service area, but I really don't see a freestanding hospital in Los Angeles for specifically being independent for many more years. I think you really have to become something bigger, whether you're going to be vertically integrated, horizontally integrated, part of a larger medical group, part of a larger system. I really think that has to happen. And my question is a freestanding ASC or an ASC owned by and partnered with a national group, national ASC company, are they really prepared for the uncertain future? I don't have the answer to the question, but I think that's something that definitely needs to be considered. Access to capital improves. And my question about a lot of the ASCs out there is the management company really interested in you and your patients, or is it just a play about short-term profits? And I think I already mentioned this before. At the end of the day, ASCs still need hospitals. Can I have the next slide, please? And my thoughts on risks of local hospital partners. We all live in a world of some physicians don't trust hospital administrators, some hospital administrators don't trust physicians. But as we go toward the future, we're all going to have to get into the same room and figure out what's the best way to take care of our patients in the most cost-effective way possible. I think the whole trust factor and the control factor will ultimately have to be disposed of in some fashion. But we all know that there are physician concerns out there that the hospital may attempt to control the physicians instead of working with them to attain the goals common to all of us and provide the best care for the patients. There's hospitals out there that hospital governance and administrators don't understand the future. I think I do. I try and work with the medical staff based on that vision of the future. But there's, I'm certain, a lot out there that don't, and even if they do, and it's perceived the reverse by the physicians, that'll be a problem. And then I think the ultimate answer is, or the ultimate question is, are physician owners ready, willing, and able to relinquish some perceived control of their ASCs to benefit from being part of an integrated system? And hospital people look at this the same way, can one hospital or one ASC or one physician come to the reality that we're all going to be part of something bigger, but we're going to have a smaller part in that? So that's really the summation of from a hospital in Los Angeles perspective on the benefits and the options available to physician owners of ASCs by becoming partners with the very hospitals that they care for their patients in. And I think
Thank you very much, Ken. Thanks so much for that detailed summary. And thanks to Fred Rosenberg as well. I think I had my phone on mute at the time we hit the transfer of the two. Anyway, I'm going to move into option 3 here, maintaining control and ownership of your ASC, and I am going to give a mixed view of all this. Next slide, please. Okay, issues to consider. Well, we've already mentioned this. Ken mentioned this, loss of control. How much control will the purchasing or partnering entity demand, whether it's a management company or your hospital? Can you retain some of your culture? Culture trumps everything in most situations. What will happen to your practice's future if your practice is integrated with your ASC? Financial issues. Do they require a management fee? Does your management company want a piece of those profits to manage what you're already doing? And what do you get for that management fee? Can you set up a laundry list and look at what you're currently paying for those various line items and compare them to what you would pay through either a management company or through a hospital? Employees, can you retain control of your employees? Some of us have been able to maintain our employees and then have the ASC lease the employees back in an effort to maintain the fact that those employees work for us. One of my personal interests is information systems. Will they force you to use their electronic medical record for the ASC or for the hospital? Will you have multiple databases that you have to enter information into and then find a way of integrating later on? Next slide. So the big question is, can we predict the future? I think we've heard multiple views of what the future is, but there are some very definite issues that permeate all of this. How will this purchase affect your ability to deal with the changes coming in healthcare reform? Will it affect your ability to join an ACO? What happens if your hospital purchases your PCP base? That may markedly decrease the value of your ASC. Next slide. So I framed what I'm going to say under three categories. Which option is best for my patients, which option is best for my practice, and ultimately, which option is best for me. Next slide. Looking at it from the patient's point of view, cost is the unavoidable agent of change for all of us. There's no role for sharing profits with an outside entity unless it brings value to your patients. The patients have to be better off because of the deal you make. We may be able to focus on the needs of our patients better if we own the center, but are we sure of that? Are we really able to focus on those issues better? Healthcare costs have obliterated increases in salaries for most Americans. Next slide. This table from Health Affairs from last year, an excellent article that I would encourage all of you to look into, shows how most Americans have had an increase in their total monthly income over a 10-year period, but taxes and healthcare costs have totally eaten up the increase in monthly income to the point that the family of four actually is realizing a decrease in their monthly income based upon these unavoidable costs, and healthcare is a major component of this. Next slide. So which option is best for my practice? Well, ASC ownership is one of the strongest features we can have for acquiring young physicians into our group. What do I think the ideal situation would be? I would love to develop a joint venture with a local hospital, form a co-management agreement, have the complex cases done at the hospital where we can hire a staff there that's focused on the high-tech procedures, the emergency procedures, the EUS, FNAs, all the complex procedures that really need highly trained personnel. Move the ASA 1 and 2 cases to the ASC where it can be done with a different level of personnel and be done more on a value-added basis. Share profits on both. Now, unfortunately, not everybody has a Ken Stropel as a CEO to speak to. Few hospitals have the insight and the guts to proceed with this kind of an arrangement. And as Ken alluded to already, many of, if not most of the hospitals are merging today, becoming part of large systems. Do they really have the ability to drill down to the level that we would need for a co-management agreement? Ultimately, the future value of your ASC is changing around you. Next slide. Co-management agreements are something we are looking into in the Practice Management and Economics Committee at the AGA. And basically, in a nutshell, what a co-management agreement requires is the formation of a third entity between the hospital and the physician group or between individual physicians. And this actually functions in an MSO-type function both entities fund the third entity. They co-manage it, and in the growing age of ACOs and shared savings that we're going to be seeing, this type of an entity can become much more and more effective for us. Next slide. But remember, Business School 101, every product has a life cycle. We have seen the life cycle of ASCs. We are all seeing decreased profits, tightening margins. We are moving over to the right side of this curve, and it is time to think out of the box. We need to beware of the opportunity cost of our capital. We have all that capital invested in the ASCs. It, to me, seems to be time to move it to places we can be more profitable. Next slide. So which option is best for me? My personal appeal is to own my own center, but it depends who you are and where you are in your career. Older physicians, like me, would love to sell and cash out. This is real estate 2007. There's an opportunity cost for your capital. On the other hand, our practice, like many others, is structured in a ladder. We have physicians at multiple ages in our practice. This is a much more difficult decision for the younger members. Can you live with your partner long term? Will your relationship affect your ability to compete? Next slide. In the end, it is a personal decision. And the bulk of all those personal decisions in a group that's making a joint voting decision will be where it ultimately is determined. Owning an ASC has probably had its glory days. It's time to make some tough decisions. If you're older, most likely it makes sense to take some cash off the table. The big question there is, who are you taking the cash off with? If you can be part of a joint venture that involves primary care doctors, other specialists, your local hospital, to position yourself for the future in a vertically integrated situation, then that makes your decision a lot easier, especially if you have leadership at your local hospital that gets it and understands the big picture. If not, if you're a much larger group and you are distributed amongst multiple hospital systems, you're in a different situation. And in that regard, a management company may make more sense for you. If you're younger, the decision is the toughest. Make sure you are entering a good long-term relationship with an entity that will help you compete. I can't advise you strong enough to look at the legal aspect of the document. Look at what the out clauses are, what your restrictive covenants are, how your medical practice will be restricted in its ability to partner with its local hospitals if you sign that agreement. These are very critical things for you to look at, and I can't emphasize how important they are. It's a lot more than just the financials that drive this decision. Well, you've heard three views, but I think there's a lot of similarity amongst the three views. And in the end, the decision is a tough one and one that is looming on all of us. So at this point, I think we're going to end the webinar. I thank you for everybody. I thank everybody for their attention, and I think I'll turn it over to staff here to tell us, do we have any questions from the audience?
Yes, we do have a few questions. The first question is, what do you think for the anesthesia model, getting paid by anesthesiologists for using the facilities?
In other words, the question there is, do you want to enter into an arrangement with your anesthesiologist? I don't know the way the question is structured. Most of the time we're not getting paid by the anesthesiologist unless there's some type of a leasing arrangement. Most of us around the country have relationships where either the anesthesiologists on one end are billing on their own and collecting on their own and you're using anesthesia merely to increase the efficiency and patient satisfaction in your center. On the other end of the spectrum, we have centers where the center itself hires usually nurse anesthetists with or without the presence of an anesthesiologist, and then they bill and make the margin on that. I certainly will be willing to listen to my two other co-presenters, but today that's an old model. That's a model that has been profitable for years for a lot of the ASCs. But our future of bundled payments will change this completely, because then we're all vying for a piece of that pie, and your revenue stream can become a cost stream with regards to the anesthesia. So I think going forward, the commoditization of our services with bundled payments will change this type of a relationship. Ken or Fred, do you have a comment on that?
This Ken. I agree with you 100%. The landscape, the reimbursement landscape, will drive that type of relationship out if it hasn't left the picture already.
Yeah.
This is Fred from Chicago. I can say that in Chicago, anesthesia at ASCs is a fairly substantial minority of patients having the procedure. And where it's done, patients and doctors never want to go back to Versed and fentanyl. It's quicker, it's a deeper anesthesia, it's a better experience. From an economic standpoint, it's not a big moneymaker for anyone but the anesthesiologist, I would guess. But from just a patient standpoint, and also the ease and efficiency of doing your procedures, for those of you that are gastroenterologists and listening, I mean, there's nothing worse than trying to get around a tough turn and the nurse telling you, oh, the patient's heart rate is 35. You sort of have to stop what you're doing to attend to that. When there's an anesthesiologist there, that's their problem, and you can just focus on the difficult colonoscopy. So it's a great thing to have, but the economics may change on it.
Any other questions?
Yes. The next question is, can you talk about three-way JVs with a hospital and management company partnering with physicians?
Well, that's a very interesting thought, because that's something that is becoming more and more popular today. The third party that would be the management piece of the MSO comes from the management company, and the physician group and the hospital group, and the hospital or group of hospitals would then have a neutral third party for the management piece, and that management company could be one of the owners in the center as well. That is a very viable model. Ken, do you have any positions on that?
Yeah, in fact, several years ago I did a lot of research on this, and as a hospital administrator, I mean, it's no secret, hospitals don't run pure outpatient services as efficiently as specialists, if you will, in that field. So for a hospital to tell you that they're going to be able to manage an ASC better or in an equal fashion with a dedicated ASC management company, they're kidding themselves. And so I'm the first person to be the advocate of getting a third party to manage it, whether or not and how much of the center they might own. It always helps to have somebody have skin in the game, but I think that's the only way to go. Otherwise, it's just different. I mean, hospital services, as everybody on this call will know, they're different. It's a whole different management structure, a whole different set of variables, and so therefore I think it's imperative to have a third party out there.
Excellent. Next question.
Yes, this question is directed for Mr. Strobel. Can you please say a bit more about the Aetna case out-of-network billing?
Well, I haven't read the details of the case, but it's based on a couple of issues. No attorney. One of them is breach of contract. But I would, instead of me trying to play lawyer, what I would suggest is just Google it, because it's been out there like for the past month, and there's a couple of editorials out there that talk about its potential impact. But if it goes the way, personally, I think it should, it's going to be, you're going to end up with a piling on. You're going to end up with Health Net. You're going to end up with Blue Cross. Everybody out there is going to go after it. So I really recommend Googling it, or there's a couple of legal papers out there on it.
Okay, next question.
Yes, in your opinion, what quality metrics, if any, are helpful during the negotiations?
I would assume that this question is negotiations with managed care companies with regards to the quality metrics. Today, and we discussed this at the Clinical Congress in a couple of sessions, there are internal metrics that you might want to be monitoring inside your own center, such as cecal intubation rates, withdrawal times, those types of things. I mean, use of reversal agents, things that should be internal benchmarks that you're comparing your physicians for. The external benchmarks are those that would be reported outside, and specifically ad nominus follow-up capture rates, complication rates, transfer rates. Those are things that would be of interest to outside parties, whereas many of the metrics that we present at clinical sessions today really should be kept internally inside your center. The question of whether cancers, the incidence of missed cancers, is affected by cecal withdrawal rates is not ready for publication or presentation outside your center. That still should remain an internal benchmarking tool, in my personal opinion. And we are working on that currently through the AGA's Practice Management Economics Committee. Next question.
Next question. How do I determine if I should sell to a hospital versus an AmSurge?
Well, that was the form plus of the entire presentation today. I think and I'll open it up to my two partners here, but this is a personalized decision based upon the situation you're in and what the makeup of your practice is. If you have a practice that is all physicians over 60 years of age, it probably doesn't matter who you sell to, you're cashing out. But that's not the situation we see in most practices, and so it is very, very much a personal decision depending on your situation. Fred, Ken?
Yeah, I would say, this is Fred, I would say that the issues you have to consider are, whoever you partner with, are these people you can be comfortable with in good times and bad? Because, when issues come up, are these people you're going to be able to get to resolution with and still be able to talk to them after it's done? That's really important for me. And, how much control do you still have in being an advocate for the patients and for the employees that have, taken the risk to work with you in this endoscopy center? Are they just going to be put into the mix of all the other hospital employees and that special relationship that I think all of us that have ASCs feel? That's something that is worth trying to retain. So I think it's relationships. I mean, the money is the money, and that's easily definable. I think it's the less definable things that you just have to be comfortable with long term.
And this is Ken, and I think there's three things that you really need to consider just with dealing with a hospital. One, does the hospital get it? Do they understand what you do? Do they understand what your future should be? Do they understand what the future of healthcare could be? And then within that context, you as a physician, owner of an ASC, how do you fit in within that? Obviously, if you've got a hospital that doesn't really understand or care about what the long-term future is going to be, probably that's not the person I would want to be a partner with. On the other hand, you're going to need, as a physician, you need options for the future. If, as Larry was talking about, if you're 67 years old and you just want to pull a ripcord and get out, that's a different discussion. But if you want to stay in the game, You're going to need options for the future because the future isn't well defined. And that then goes to the issue of do you have a relationship with your local hospital that can help you in that from that vantage point and provide options for the future, or at least assist you in the provision of those options. And I think a lot of this will also have to do with where physically is your practice, what part of the country. We all know, if it happens in Louisiana, it might be at a different velocity and a different form that it might happen in California. The employment of physicians is a big issue. So there's a lot of things to consider, but I think it really comes down to, if the option is a local hospital, do they really understand the future, and are they going to be viable for the long term?
These are both great inputs, and I can't emphasize more the fact that this is a local decision. Each and every market is different than each and every other one, and the national companies will have a national approach to this. The questioner specifically said AmSurge. AmSurge has a very standard national contract. You have to then take that national rigidity and apply it to your local market, which may not fit. So, you always have to look at the hospital situation you're in, the primary care situation you're in. This could vary as to whether you have a large vertically integrated medical group that you're part of, or whether you're in a more of a fragmented environment, whether you have dominant hospitals, weak hospitals. You have to look at the local environment before you can make that decision. There's no one-size-fits-all on that. Next question.
There are no other questions at this time.
Okay. Well, I'd like to thank my other two panelists. I think this was a very informative session for our listeners. And if I'm not mistaken, this is being recorded and will be available to membership later. Is that correct, Amy?
Yes, that's correct. And the Q&A will be posted online as well.
Okay. And I think we're even working on a forum that will go from this presentation on towards the period between now and DDW. We are going to have a session addressing this very topic